Your doctor has recommended that you undergo hip replacement surgery, but what does that actually mean? The hip joint is the place where the thigh bone, called the femur, and the hip bone, called the pelvis, meet. As you walk, the ball-shaped end of the thigh moves within a cup-like depression on the side of the hip. As long as the thigh can move smoothly against the hip, you're able to walk comfortably. But over time, especially in patients who suffer from arthritis or rheumatism, the hip joint can wear down. Cartilage, the tissue that cushions the bones and makes it possible for them to move smoothly against each other, can wear away. When this happens, the bones rub together, causing pain and even restricting the ability to walk. In some cases, hip surgery is recommended for people who have suffered a hip fracture. No matter what the cause, one of the most effective ways to fix a damaged hip is to replace it surgically. In this procedure, the ball-shaped bone at the top of the thigh is removed and replaced with a metal substitute. The hip socket is widened and lined with a smooth pad that allows the metal ball joint to move more freely against the pelvis. Hip replacement surgery is a major operation, but your doctor believes that the procedure, followed up with physical therapy and time to heal, will result in reduced pain and greater mobility. When it comes to hip replacement surgery, there are no real alternatives. Physical therapy can sometimes reduce stiffness and increase flexibility, but it cannot cure the underlying disease. However, hip replacement surgery is an effective way to improve your ability to walk and reduce pain. Choosing not to undergo hip replacement surgery will not normally put your health or life at risk, but it is very unlikely that your damaged hip joint will heal. So without surgery, it is almost certain that your condition will not improve and may become worse over time. Of course, no surgical procedure is completely risk-free, but your physician feels that if you decide not to undergo the recommended procedure, your quality of life will not improve, and your ability to walk normally will be reduced.
On the day of your operation, you will be asked to put on a surgical gown. You may receive a sedative by mouth, and an intravenous line may be put in. You will then be transferred to the operating table.
In the operating room, the anesthesiologist will begin to administer anesthesia, probably general anesthesia by injection and inhalation mask. The surgeon will then apply antiseptic solution to the skin and place a sterile drape around the operative site. Then, when you are asleep, the surgical team will make an incision over the hip and along the thigh. The team will pull the skin aside to reveal the muscle tissue below. They will then make another incision to reveal the hip joint. Next, the team pulls the top of the thigh bone out of the hip socket. Using a precision surgical saw, your doctor will carefully remove the ball-shaped end of the thigh bone. Then the surgical team will use a high-speed drill to hollow out the top of the thigh bone. A specially fitted artificial ball joint slides into the top of the thigh bone. Next, your doctor will smooth the inner surface of the hip socket. Once the hip socket has been thoroughly cleaned, the artificial lining will be secured and placed with special screws. The artificial ball joint is turned inward and fit into the socket. The team carefully checks to make sure that it fits and allows the full range of normal motion. Muscle and other tissues are closed over the joint using dissolvable stitches. A temporary draining tube may be added. Finally, the skin is closed with sutures and protected with sterilized strips.
Most patients experience at least some pain following surgery, but if properly handled, it shouldn't present any serious problems. Pain used to be regarded as an unavoidable side effect of surgery, but today, pain can be managed with great effectiveness. And as the patient, you have an important role to play. Before surgery, be sure to ask the medical staff about the type and duration of pain normally associated with your surgery. Find out in advance about your pain management options. Work with the staff to develop a pain management plan. Discuss your options. There are alternatives to drugs that can lessen your need for pain medication. Ask your doctor for help in finding a pain management class. Many of these workshops teach helpful relaxation techniques, positive thinking, and nerve stimulation exercises. Following surgery, make sure to let your nurse know right away how you're feeling and whether or not you are in any pain. Be specific and help them to measure your discomfort. If you're having trouble expressing yourself, try to rank what you're feeling on a scale from 1 to 10. Never be shy about asking for help. If you experience pain that just won't go away, report it to the nurse. Pain is an important indicator that helps you and your medical staff understand your body's healing process. At some point, you'll be moved to your room. While you're in the hospital, doctors and nurses will regularly check you, monitoring your progress following surgery. It's important that you realize your time in the hospital is an extension of the surgical procedure. While you're in the hospital, your medical team will continue to monitor your body's immediate reaction to the procedure just performed. That means that your time in the hospital is not really for rest and recovery, and you should expect to have your movements restricted and even your sleep interrupted by nurses or other medical staff. The amount of time that you spend in the hospital would depend on your age, your health, and whether or not any complications arise. Be assured that once your doctor feels that your condition is properly stabilized, you will be allowed to leave. Be sure to follow your doctor's advice and allow the full recommended period of time before you return to your normal routine.
Hip replacement surgery rarely leads to complications. It is possible that one or both of the artificial components could come loose, requiring another operation. Muscle, nerve, or bone damage is also possible, although very unlikely. Another possible complication is a persistent residual neuralgia, or pain around the scar. It can be either localized or general. It may develop soon after surgery, or even weeks or months later. In rare cases, the surgery does not restore full mobility or stability to your hip and thigh.
Germs are present always on your hands, and they can be transferred to other parts of your own body, to the family member for whom you're caring, your patient, and to any clean object you touch. By washing your hands correctly, you remove germs from your hands. Hand washing is the single most important way you can prevent infection from occurring. and prevent the spread of infection. You must carefully wash and dry your hands before and after each time you care for your family member, your patient. Before and after you handle your patient and your own food and drink. Before and after you manipulate any contact lenses. Before you apply and after you remove gloves. After you use the toilet. After you cough, sneeze, or blow your nose. After contact with anything that could be soiled or have germs on it. After you pick up any object from the floor. Hand washing takes a minimum of 10 to 15 seconds, longer if your hands are soiled. The longer you wash, the more germs are removed. The friction generated by rubbing your hands together removes the germs from your skin, and running water can then wash them away. Every time you wash your hands, take your time and don't rush. Do the hand washing carefully and thoroughly. Use liquid soap from a dispenser. Bar soap holds germs on its surface. Make sure you have paper towels and a waste receptacle nearby. Remove all jewelry from your hand except a wedding band, and push your watch and sleeves up away from your hands. Turn on warm water. Point your fingers down to prevent water running onto your arms and wet your hands. Apply soap from the dispenser. Point your fingers down and rub your hands vigorously together in a circular motion. Start counting seconds at this point. Intertwine your fingers to clean all surfaces of the fingers. Rub your fingernails against the palm of the other hand to get soap under the tips of the nails. If your nails are soiled, clean under them with an orange stick or brush. Keep your hands down and continue to rub them together in a circular motion until the end of your count for 15 seconds. Keep your hands down and rinse them from the wrist to fingertips. Pick up a clean paper towel and turn off the water, still keeping your hands pointed down. Discard the paper towel into the waste receptacle. Pick up another clean paper towel and carefully and completely dry your hands. Discard the paper towel into a waste receptacle. The key points to remember are that friction is critical for removing germs, and the friction should be applied for at least 15 seconds. Always keep your fingers pointed down and turn off the water with a paper towel. Your correct use of disposable non-sterile gloves helps prevent the spread of infection and protects both you, the caregiver, and the person receiving care, your patient. The gloves used most often are made of latex, are powder-free, and are easy to put on and take off. They are used once only and then discarded. Gloves are not worn all the time in giving care. Touching your patient with bare hands shows love and respect, sends a message of caring and acceptance, and provides comfort. Gloves should always be worn if contact is likely to occur with blood, body fluids, excretions such as urine or feces, mucous membranes such as in the mouth or genitalia, or non-intact skin. Before you put gloves on, carefully wash and dry your hands. Pull a glove out of the box with one hand and slide it onto your other hand. With your gloved hand, pull another glove out of the box and slide it onto your bare hand. Interlace your fingers to make the gloves fit more smoothly and comfortably. You should remove your gloves immediately when the patient care procedure is complete, if the gloves are heavily soiled, if a glove is torn, after you have touched your patient's secretions or excretions, before touching another part of the body, before touching any clean surface or object. When you remove your gloves, your intent is to avoid touching the contaminated surfaces of the gloves with your bare hands. To take off your gloves, firmly grip one glove at the base of the palm and pull it off inside out. Keep holding it in the palm of your gloved hand. Slip your bare fingers under the wrist of the remaining glove without touching its surface. Push the glove down and off with the first glove tucked inside of it. One glove is now inside the other and both are inside out. Drop the bundle of gloves into a sealable plastic storage bag and seal it tightly. Drop the sealed bag into the trash. Carefully wash and dry your hands. The equipment you will need to assemble includes 2 pairs of clean disposable gloves, cleansing solution, small gauze pads for cleaning, large gauze pads for dressing the wound, adhesive tape, a large sealable plastic bag. Carefully wash and dry your hands. Put on your gloves. The first step is to remove the old dressing. Loosen the edges of the tape and peel the tapes off the skin by pulling them towards the wound, keeping the skin taut with the other hand. Lift the tapes and the dressing off together. Note any odor or color of any drainage on the dressing. Discard the dressing and tapes into the plastic bag. If the dressing sticks to the wound, pour a little cleansing solution onto the dressing and let it sit for a minute. Gently pull the dressing off, keeping the skin taut above the wound. Look carefully at the wound. Any of the following should be reported immediately to your doctor or nurse: redness of the wound or surrounding skin, drainage from the wound, particularly if it's yellow and smells, any bleeding, swelling of the skin around the wound, separation of the edges of the sutured wound, or maceration, a waterlogged appearance of the edges of the wound. Pour some cleansing solution onto a small gauze pad. Squeeze out the surplus solution and with one stroke, clean the wound from top to bottom. Discard the gauze pad into the plastic bag. Using a fresh gauze pad with cleansing solution for each stroke, work away from the wound to clean the skin for about 3 inches from the wound on either side. Stroke from top to bottom and discard each gauze pad into the plastic bag. Remove your gloves and discard them into the plastic bag. Wash and dry your hands. Open the package with the large gauze dressing. Put on clean gloves. Pick up the gauze dressing, holding it only at 2 diagonally opposite corners. Center the gauze pad over the wound and place it on the wound. Tape the dressings securely in place. Remove your gloves and discard them into the plastic bag. Seal the bag securely and discard it into the trash. Wash and dry your hands. If your skin is sensitive to the adhesive on the tape, hypoallergenic tape can be bought at your surgical supply store, or bandages or binders can be used to hold the dressing in place. Consult with your doctor or nurse. Sometimes after surgery, your patient may need help with feeding. Before serving the food, make the environment as attractive as possible. Complete any toileting needs your patient has. Help your patient wash his hands. Make sure the patient has any dentures, glasses, or hearing aids that are used. If your patient is able to get out of bed, help him sit at the table in a straight-back chair so that the tabletop is at a comfortable height and distance so that he does not have to stretch to eat. Before serving the food, wash and dry your hands. Display the food conveniently and attractively and describe it to your patient. If your patient is staying in bed, use pillows so that the patient is comfortably upright. If you are using an overbed table, remove any objects on it and wipe it with a damp paper towel. Before serving the food, wash and dry your hands. Use a towel or a bib to protect clothing and bed covers. Place a tray with the food on the overbed table and describe the food. Prepare any food such as opening and pouring containers of fluids, buttering bread, using condiments, cutting food. Sit at the patient's side, at or below eye level. If you're right-handed, sit at the patient's right side so that your patient does not have to keep his head turned towards you. Use a fork half full of solid food or a spoon half full of liquid. Always encourage your patient to feed himself as much as possible. Liquids should be given frequently, either with a spoon or a straw. Use a napkin or paper towel to wipe your patient's mouth if needed. When a patient has finished, remove the tray and help him to wash his hands and face and brush his teeth. If need be, help him with toileting. Wash and dry your hands. A peak flow meter is an inexpensive portable handheld device. Your doctor or nurse will advise you which make and type to use. The device measures how hard and quickly you can blow air out of your lungs. The meter has a marker that slides up the scale as you blow out. The better your lung function, the harder you will be able to blow out, and the higher your peak flow score will be. Monitoring your peak flow numbers shows how your lung function is improving, the effect of such treatments as breathing exercises on your lung function, and when your lung function has returned to its pre-surgery level. To use your peak flow meter, first make sure the marker on the meter scale is at 0. Preferably stand or sit up straight. Remove any gum or food from your mouth. Hold the peak flow meter horizontal with your fingers away from the scale. Take as deep a breath in as you can. Close your lips firmly around the mouthpiece and blow out as hard and as fast as you can, just like blowing out candles on a birthday cake. Check the reading on the meter scale. In this case, 400 liters per minute, and write it down. Move the marker back to 0. Repeat the entire routine 2 more times for a total of 3 times. The 3 readings you get should be close together. Record the highest of the 3 readings in your log or diary. Your doctor or nurse will tell you how often and when each day to record your readings. Take your log with you when you return for follow-up visits to your surgical team. They will be able to monitor your progress and see when your lung function has returned to its pre-surgery value. This program provides you with tips to help you get out of bed after abdominal or chest surgery. For the first few days when you come home after surgery, it's always best to have a family member or friend help you to get out of bed. Do not get out of bed directly from lying flat. Always sit up in bed for a few minutes. Move the bed covers well out of the way. Move nearer to the side of the bed. Pivot your body and legs so that you are sitting with your legs dangling over the side of the bed. Hold the mattress with your hands for support and keep your back straight. Gently swing your legs back and forth. Bend and stretch your ankles and twiddle your toes. If you feel faint or weak, go back to bed. Have your helper put on your socks and shoes or sturdy slippers with low heels and non-slip soles. Use a footstool if the bed is too high for your feet to reach the floor without sliding off the bed. Stand still on the floor with your feet slightly apart for a few seconds. Have your helper put on and fasten your robe. For the first few times out of bed, when you feel strong enough, walk a few steps to a bedside chair with arms. When you reach the chair, turn around so that your calves are touching the front of the chair. Bend your knees, grasp both arms of the chair firmly, and lower yourself backward into the chair. Reverse the process to get out of the chair. At any time, if you feel weak or dizzy or have chest pain, let your helper get you back to bed and inform your doctor. Some additional tips for the helper to follow. Make sure your own footwear has non-slip soles. Remove any hazards from the floor, such as slip rugs, frayed carpet or linoleum, or electrical cords. Stand at the side of your patient, not directly in front. Avoid lifting your patient under the arms. This can cause pain or dislocation of the shoulder joint. Never let your patient put arms around your neck. The key to safely helping a frail or weak patient out of bed is to use a transfer belt. This is a heavy canvas belt, 2 to 3 inches wide. It can be purchased at your surgical supply store. Use of the transfer belt provides safety for you and your patient, provides a feeling of comfort for your patient, gives you control if the patient starts to slip or fall, and prevents injury to you or your patient. A regular leather or material belt should not be used as a substitute for a transfer belt. Do not use a transfer belt if your patient has had recent abdominal surgery, has a colostomy, or a gastostomy with a feeding tube going directly into the stomach, has severe cardiac or respiratory disease, or has fractured ribs. If your patient has been lying flat, always sit the patient up for a few minutes before moving him out of bed. Move the bed covers well out of the way. Bring the patient nearest to the side of the bed and help the patient pivot so that he is sitting with legs dangling over the side of the bed. Let the patient sit for a minute. If the patient feels weak or faint, help him back to bed. Help the patient put on a robe, socks, and shoes or sturdy slippers with low heels and non-slip soles. Place the transfer belt around the patient's waist with a buckle in front. The belt is always applied over clothes and must never touch the patient's skin. Thread the belt through the buckle, teeth side first, pull it snug, and thread the belt back through the buckle for security. Tuck the loose end in the belt. The belt should be snug with enough space between the belt and the robe for your fingers side by side. Have the patient place both feet on the floor, or footstool if necessary, about 12 inches apart, and both hands palm down on the mattress at a side. Place one of your legs between the patient's legs and slightly bend your knees. Grasp the transfer belt from underneath with one hand on either side several inches away from the buckle. Have the patient lean forward and, on the count of 3, push off the bed with his feet and hands to stand up. You use the belt as a support and do not pull the patient up with it. Allow the patient to stand still until he is comfortable. If the patient is weak or faint, help the patient back to bed. You stand to the side and slightly behind the patient. With one hand, hold the belt. With an underhand, grasp at the back of the patient. Support the patient in the same way as he walks to a nearby chair or commode, both of which have arms. When the patient reaches the chair, use an underhand grasp on the belt from the front with one hand on each side of the buckle. Have the patient pivot until his calves touch the front of the chair. The patient then bends his knees, grasps the arm of the chair with both hands, and slowly sits down as you support him. The procedure is reversed to have the patient get back to bed. Always encourage the patient to do the work and be independent, and remember to use the belt as a support tool and not as a pulling device. If the patient starts to fall, Grasp the belt with both hands at the back of the patient, a foot apart. Pull the patient close to your body and slide him down your body to the floor. Bend your knees as you do this. Support and lower the patient's head once his body is on the floor. A closed urinary drainage system consists of a catheter inserted into the urinary bladder and connected via tubing to a drainage bag. The catheter is retained in the bladder by an inflated balloon. The drainage of urine is totally dependent on gravity. Therefore, tubing and the drainage bag to collect urine must always be below the level of the bladder. As a caregiver, your responsibilities to a patient with a closed urinary drainage system are to ensure that the patient drinks at least 8 ounces of fluid daily, preferably water and juice. To ensure that the catheter and tubes are in a good position and open to allow urine to flow freely into the drainage bag, and to keep the body opening where the catheter enters the patient clean and free from secretions. Ensure that the catheter and drainage tube are connected and that there is sufficient slack in the tube between the body and the thigh to allow the patient to move the thigh without pulling on the catheter. The drainage tube should be attached to the patient's leg by a tie or clip. The drainage bag can be attached to the bed frame, should never touch the floor, and should always be kept below the level of the patient's bladder. The drainage bag should be emptied at least daily, more often if it fills, in order to prevent infection in the system, reduce odors, and keep the system open and flowing. To empty the drainage bag, the following steps should always be followed. Carefully wash and then dry your hands with a paper towel. On a tray covered with clean paper towels, assemble the following equipment: a large plastic or glass container, a large plastic sealable storage bag, disposable gloves, alcohol wipes, paper towels, and place the tray on a stable surface adjacent to the bed. Carefully wash your hands, dry them with a paper towel. Discard the paper towel into a wastebasket. Put on your disposable gloves. If you are cleaning your own catheter, gloves are not essential. Place the container under the drainage bag. Remove the drain from its holder. Point it into the container and release the clamp on the drain to allow the urine to flow into the container. Do not allow the drain to touch the container or anything else. When the drainage bag is empty, close the drain, wipe the end of the drain with an alcohol wipe, and replace the drain in its holder at the base of the drainage bag. Discard the alcohol wipe into the plastic storage bag. Check that the catheter and tubes are in place. Take the equipment tray and the container of urine into the bathroom. If your doctor or nurse has asked you to record the amount of urine, measure and make a note of it now. Discard the urine down the toilet and clean the container with liquid soap and water. Remove the gloves and discard them into the plastic storage bag. Seal the bag and put it into the trash. Wash and dry your hands. Discard the paper towel into the trash. Once each day, or according to your doctor's instructions, you will need to clean the urethral meatus, the opening where the catheter enters the body. The drainage bag should be emptied every 6 to 8 hours, more often if it fills, in order to prevent infection in the system, reduce odors, and keep the system open and flowing. To empty the drainage bag, the following steps should always be followed. Carefully wash and then dry your hands with a paper towel. Discard the towel into a plastic-lined wastebasket. On a tray covered with clean paper towels, assemble the following equipment: a large plastic or glass container, a large plastic sealable storage bag, disposable gloves, paper towels. Place the tray on a stable surface adjacent to the bed. Carefully wash your hands, dry them with a paper towel. Discard the paper towel into the wastebasket. Put on the disposable gloves. If you are emptying your own bag, there is no need to use gloves. Place the container under the drainage bag. Remove the drain from its holder. Point it into the container and release the clamp on the drain to allow the urine to flow into the container. Do not allow the drain to touch the container or anything else. When the drainage bag is empty, close the drain. Replace the drain and its holder at the base of the drainage bag. Check that the catheter and tubes are in place. Take the equipment tray and the container of urine into the bathroom. If your doctor or nurse has asked you to record the amount of urine, measure and make a note of it now. Discard the urine down the toilet and clean the container with liquid soap and water. Dry it thoroughly with a paper towel and discard the paper towel into the trash. Remove your gloves and discard them into the plastic storage bag. Seal the bag and put it into the trash. Wash and dry your hands. Discard the paper towel into the trash. Some patients are able to wear a leg bag during the day to allow them to walk about. The larger drainage bag is disconnected from the catheter in order to attach the leg bag. The leg bag is secured to the front of the thigh or lower leg. After it's been disconnected from the catheter, the larger drainage bag can be unhooked from the bed frame, carried into the bathroom, and emptied directly into a measuring device or the toilet. Following surgery, you may have a suprapubic catheter or be on a program of intermittent self-catheterization as your bladder recovers from the effects of surgery. To help your bladder heal, you will need to increase the time between self-catheterization or unplugging the suprapubic catheter until there is no need for a catheter. To know the time intervals needed between catheterization or removing the plug, you need to keep a record of the amount of urine you are producing when you void and when you catheterize or unplug. You should try to void every 2 to 3 hours and immediately before you self-catheterize or remove the plug. Void into the hat placed into the toilet and measure the amount of urine in the hat. This amount is called the voided volume. Write this amount on your record sheet every time you void. When you self-catheterize or unplug, measure the urine that empties from the catheter. This amount is called the post-void residual, or PVR, and is written down on your output record sheet in the PVR column. Look at your output record sheet. Each entry on the record will have a date, time, and the amount of urine in either the voided volume column or the post-void column. Your output record can be taped to the back of the bathroom door to keep it handy. The basic guidelines for the timing of self-catheterization or plug removal during bladder retraining are Throughout the day, void as often as you like, at least every 2 hours. Measure each void in the hat. Write the amount in the voided volume column of your output record. Begin by self-catheterizing or unplugging the suprapubic catheter every 4 hours. Immediately before catheterizing or unplugging, void into the hat, measure the volume and write it in the voided volume (VV) column of your output record. When you self-catheterize or remove the plug, save and measure the urine that comes out of the catheter and write the amount in the post-void residual (PVR) column of your output record. If your post-void residual urine (PVR) is less than 150 cc's, you can increase your time intervals between catheterizations or plug removal by 2 hours, say from 4 to 6 or 6 to 8 hours. If your post-void residual urine (PVR) is between 150 and 250 cc's, you should keep the time interval between catheterizations or plug removal the same. If your post-void residual urine (PVR) is more than 250 cc's, you should decrease the time interval by 2 hours. Try not to self-catheterize or remove the suprapubic catheter plug more often than every 4 hours, unless you feel uncomfortable or full. Start in the morning from where you left off the previous day. You do not need to start over each day. Keep your output record to show your healthcare providers. Once you are consistently at 12-hour intervals between catheterizations or plug removal, consult your healthcare provider, who may tell you to stop the retraining process. The retraining process may take several weeks or even months. Do not get discouraged. Let's look at an example of a recording. In the morning, you wake at 8 a.m. and you could not void any urine. Point 0 is recorded in the voided volume (VV) column. Then you catheterize and produce 300 cc's of urine. This is recorded in the post-void residual (PVR) column. From the basic guidelines, you know you must wait 4 hours until the next catheterization or plug removal, unless you are uncomfortable. You will attempt to void every 2 hours and record the amount you void in the voided volume (VV) column. At 12 noon, you void 100 cc's and record this in the voided volume (VV) column. The 4-hourly catheterization or plug removal produces 150 cc's of urine, and this is recorded in the post-void residual (PVR) column. From the basic guidelines, this means you continue with 4-hourly catheterizations or plug removal. At 2 p.m., you voided 90 cc's and recorded this in the VV column. At 4 p.m., you voided 150 cc's and again recorded it in the VV column. You catheterize or remove the plug and produce 100 cc's of urine, which is recorded in the PVR column. Basic guidelines tell you that the next catheterization or plug removal can be moved out to 6 hours because your PVR was below 150 cc's. During the evening, you voided at 6 p.m. and 8 p.m. and recorded these amounts in the VV column. At 10 p.m., your voided volume is 175 cc's and your PVR on catheterization or plug removal is 125 cc's. Because your PVR is again below 150 cc's, you can increase the time between catheterization or plug removal from 6 to 8 hours. When you are self-catheterizing or removing the plug every 12 hours, you must set your alarm at night so that you will wake and attempt to void every 3 to 4 hours. Record each void in the VV column of your output record. The following problems or symptoms are reasons to contact your healthcare provider immediately. Little or no urine flow, cloudy or foul-smelling urine, sand-like material in the urine, bloody urine, a red or swollen urinary opening, difficulty inserting the catheter, pain in the lower back or lower abdomen, chills or temperature above 100.5 degrees. The supplies you will need to have easily accessible in the bathroom include clean clothing, skid-proof plastic bath mat, 2 washcloths, 2 towels, soap, shampoo, plastic pitcher, skin lotion, comb and brush, disposable gloves, and a sealable plastic storage bag. Ensure that the bathroom is pleasantly warm, around 70 degrees. Place the skid-proof plastic bath mat in the tub and fill 1/3 of the tub with warm water. Test the temperature of the water with your hand. Wash and carefully dry your hands. Put on your disposable gloves. Help your patient undress and place soiled clothing in the plastic bag in the laundry hamper. Help your patient sit on the edge of the tub. If there's a grab bar on the back wall of the tub, have the patient hold it with one hand. Swivel and lift both legs into the tub. From the back, support your patient under both arms and help him slowly lower his body into the water. Encourage your patient's independence and have him do as much of the washing as possible. You may need to assist in such areas as the patient's back, and to rinse off all soap with a shower extension or a pitcher. If it's shampoo time and the patient cannot do it himself, you can have him hold a dry, folded washcloth over his eyes to protect them. Pour clean, warm water over the patient's head using a pitcher or shower extension. Rub in shampoo and massage the patient's head. Rinse off the shampoo with clean, warm water, using a pitcher or a shower extension. Dry the hair. If possible, have the patient stand and help him dry his upper body. Otherwise, dry his upper body and arms with him sitting in the tub. Let the water out of the tub. With a towel over his upper body, help the patient sit on the edge of the tub. Support the patient and help him swivel his legs over the edge of the tub. He can rest for a while if need be. Help dry the rest of the body, paying attention to under the arms, other skin creases, and in between the toes. Apply body lotion to the skin and help the patient dress. After making your patient comfortable, return to the bathroom. Place soiled towels and washcloths in the laundry bag. Clean the tub and mop the floor. Remove your gloves, discard them into the plastic storage bag. Seal the bag and place it in the trash. Carefully wash and dry your hands. The supplies you will need to have easily accessible in the bathroom include clean clothing, skid-proof plastic bath mat, 2 washcloths, 2 towels, soap, shampoo, plastic pitcher, skin lotion, comb and brush, disposable gloves, and a sealable plastic storage bag. Ensure that the bathroom is pleasantly warm, around 70 degrees. Place the skid-proof plastic bath mat in the tub and fill 1/3 of the tub with warm water. Test the temperature of the water with your hand. Wash and carefully dry your hands. Put on your disposable gloves. Help your patient undress and place soiled clothing in the plastic bag in the laundry hamper. If your patient is not strong enough to get into the tub or stand upright long enough to take a shower, you can use a bath stool or a bath seat across the tub. Help your patient sit on the edge of the tub. If there's a grab bar on the back wall of the tub, have the patient hold it with one hand. Swivel and lift both legs into the tub. With the patient seated, it's easiest and most comfortable for the patient to use a shower extension. Again, encourage the patient to do as much as possible for himself. You may have to help with the back and to make sure all soap is rinsed off the skin. If it's shampoo time and the patient cannot do it himself, you can have him hold a dry, folded washcloth over his eyes to protect them. Pour clean, warm water over the patient's head using a pitcher or shower extension. Rub in shampoo and massage the patient's head. Rinse off the shampoo with clean, warm water using a pitcher or a shower extension. Dry the hair. If possible, have the patient stand and help him dry his upper body. Otherwise, dry his upper body and arms with him sitting in the tub. Let the water out of the tub. With a towel over his upper body, help the patient sit on the edge of the tub. Support the patient and help him swivel his legs over the edge of the tub. He can rest for a while if need be. Help dry the rest of the body, paying attention to under the arms, other skin creases, and in between the toes. Apply body lotion to the skin and help the patient dress. After making your patient comfortable, return to the bathroom. Place soiled towels and washcloths in the laundry bag. Clean the tub and mop the floor. Remove your gloves, discard them into the plastic storage bag. Seal the bag and place it in the trash. Carefully wash and dry your hands. If you have a walk-in shower and the patient's strong enough to stand for a shower, the helper may need to stay with him and generally help with the procedure.